welcome to the second Human Health Law Policy and Ethics Seminar here at the European Faculty of Law. My name is Tudo Lemmens, for those who are not familiar with the Health Law Seminar Series. I'm very happy to have a panel today on a topic that is very hot, very timely in the Canadian context, since Canada will start introducing or start practicing allowing from March 2023, so in a couple of months, medical assistance in dying for the sole reasons of mental illness. Not many countries in the world, actually two major countries that have been practicing this for the last decade, at least a little bit longer, Belgium and the Netherlands. And so we don't have a lot of experience, not a lot of evidence from what's happening in those countries and what are the challenges. We have had a federal commission which report in the Canadian context, which we will be able to discuss during the question period, and I would be interested in hearing as well the comments from our commentators and from the speaker about that. But the focus of today is really an informative session led by Dr. Marie Nicolini, who has an MD, PhD, who has done actually her doctoral research on medical assisted dying or euthanasia and assisted suicide, as it is called in Belgium and Netherlands, and countries, in many countries, or in the few countries that actually legalized the practice before. And she has done a doctoral dissertation precisely on some of these issues and has published recently a paper that I think is important also in the Canadian context to discuss, which is the overlap between on the overlap between gender and medical assisted in dying for mental disorders. So without further ado, I'll briefly introduce the speaker. And I'm very happy that we actually have three different commentators as well, who I will introduce now. We will then have the presentation and immediately follow that by the commentaries. And then we'll open it up for questions. I have some questions received from students who take this seminar as a course. But then we will open it up to the audience. We will primarily have a discussion with people here in the room, but I will myself open check in the chat box if I can introduce also some questions from the audience who is online. So Dr. Nicolini is, as I said, a psychiatrist and ethicist with research interests focused on autonomy and decision-making capacity and health practice policy. As a psychiatrist in Belgium, and I had the honor of being examiner on her PhD in bioethics, which was a postdoctoral fellow in bioethics at the National Institute of Health. And she's currently a senior researcher at the KU Leuven and a visiting scholar at Georgetown University. She's done extensive original research, as I said, on the topic of MAiD for mental disorders. So after her, we will have a local psychiatrist, Dr. Urvashi Prasad. She's a fourth-year psychiatry resident, University of Toronto, has completed her undergraduate medical degree from the University of Toronto, and has a bachelor's in science from McGill University. And she has developed a keen interest on the topic of medical assisted in dying and has already given a grand rounds on that. After that, we have Samantha Welsh, who is the National Director of DAWN, the Disabled Women's Network of Canada. Her passion for disability justice is personal and professional. She has cerebral palsy and she identifies as disabled. She believes that disability is an identity that is open to everyone, as one can become disabled at any time. Samantha holds a PhD in sociology from the University of Toronto OISE, and her doctoral research is in interpretive sociology with a focus on disability and social inclusion. After that, last but not least, we have Isabel Grant, who is a professor at the Allard School of Law at UBC, whose work focuses on criminal justice responses to violence against women and girls. She also works with a number of disability organizations on strategic litigation. She is a member of the BC Bar and a fellow of the Royal Society of Canada. So Isabel, Professor Grant, will be able to bring it back to an audience of primarily, I would say, lawyers and law students and law scholars.
Trudeau, can I just interrupt for a minute and say there's a lot of background noise? I don't know if other people online are hearing that as well. It sounds like someone's shuffling papers or something right next to the microphone.
I open it up to Mary. Okay, Mary.
Because people are eating in the room. So the mic right there is in the center of the room and it's really sensitive. So if people are shuffling, it can pick it up. Yeah. Yes.
Can everyone see this? Okay, hi, thank you so much for having me. It's really a pleasure to be here and to talk to this wonderful audience. So I will be talking specifically about the tension between suicide prevention and MAiD for mental disorder and what the conceptual challenge is. I'll be presenting my work, which is funded by the Belgian Research Foundation Flanders. And so here's an overview of what we'll be talking about today. So we'll start with, okay, what is this tension really about and why it matters? And then we'll look at 3 strategies to make a distinction between suicide prevention and MAiD for mental disorders. First strategy, can we distinguish clinically? Second strategy, can we distinguish conceptually? And third, can we distinguish on a case-by-case basis? And I will conclude that each of these 3 strategies fail and what this means for policy making. All right, so introduction. I'll start by defining what we understand by suicide prevention and by MAiD for mental disorders so that we're clear. So suicide prevention is the collection of efforts to reduce suicide. By that, we mean both the clinical measures, clinical management, which is typically done by psychiatry, and the public health measures that target specific population level suicide risk factors. Suicide prevention is a pillar of public health worldwide. And if we look here at the numbers, and apologies for starting with this upfront, but just to sort of keep in mind as we go through the talk that of course, this affects a lot of people, right, around the world, not only in Canada, but here's an example. We're talking about 4,000 suicides per year in Canada. The ratio of completed to attempted suicides is 1 to 20, so 80,000 attempts per year. And it's the attempts that we need to bear in mind. And as you see on the right, 3% have attempted suicide in their lifetime. So calculated for the Canadian population, that's over 1 million people. Okay, MAiD for mental disorders then. Medical assistance in dying based on a mental disorder, right? So that's what we're talking about. Now, the key legal requirements are the same as for physical disorders, as for terminal disorders, and they are the same across jurisdictions that allow for this practice. So we have an informed voluntary request, unbearable suffering, and irremediability. Now, if we see here, for example, this is to show, right, that the 3 requirements are the same across jurisdictions, even though, of course, the wording will be different, right, depending on the country. But so if we look at, so voluntary well-considered request, unbearable suffering, and irremediability. If you look specifically at irremediability, we see, for example, the Netherlands say there should be no reasonable alternative. Belgium says an incurable, the incurable nature of the disorder, right? The serious and incurable disorder. Same with Luxembourg, and in Canada says a grievous and irremediable condition. Okay, now a very brief summary of the Canadian situation, which I'm sure you're aware of, right? But to situate this, so 2016, the Canadian MAiD law came into effect. In 2019, the reasonably foreseeable death requirement was struck down after the Truchon versus Canada court ruling. which led to MAiD based on a non-terminal disorder to be permitted. And that then raised the question, which is debated up until today, of whether MAiD based on a mental disorder should be permitted. And so this is a central claim for today, right? There's a tension between MAiD for mental disorder and suicide prevention. And that raises an urgent and unresolved conceptual challenge. To illustrate what the tension is about, I'll illustrate with a few quotes. So here's a quote from the Canadian expert panel report, right, of this year, that says, well, while it might be more straightforward to rule out suicidality at the end of life, or for persons with no history of suicidality themselves, like Truchot and Gladue, this may be more difficult in persons with chronic suicidal thinking and behavior who request MAiD. Right, so that's the Canadian report. When we look at the Dutch Psychiatric Association guidelines, so they issued their first guidelines back in 2009, and this is the revised edition in 2018, where they say suicidal behavior is increasingly being articulated by the patient as a request for MAiD. After all, they say the term MAiD is becoming more and more common in the media, and patients increasingly adopt this language in a different context. A request for assistance in terminating life that in fact is an expression of underlying suicidality may lead the physician astray. So it's that last sentence that's important, right? They're saying, look, it's gonna come up. People are gonna ask for it, understandably so. And it's really the task of the psychiatrist to know, well, how are you supposed to respond to this, right? Are you supposed to respond like this were a case of suicidality and you continue with your treatment efforts? Are you supposed to proceed with the request, right? Which way are you supposed to go? So that's the crucial question, really. It's a clinical question, and as we'll see, it's also a conceptual question. So why is this a problem for policy, right? The question is MAiD for mental disorders compatible with suicide prevention? And if so, how, right? So how is important. And I'll walk you through here this flow chart just to make sure we're clear on what we're talking about and what we're not talking about, right? So often, so we start here with the tension between suicide prevention and MAiD, right? Which we all agree exists. Often the way the distinction is made is between acute suicidality and MAiD, right? So think of acute breakup and someone wants to die, right? Can't cope with it and attempt suicide. I'm gonna bracket this, right? I'm gonna assume this is not what we're talking about. The real tension is between chronic suicidality and MAiD, right? So people whose death wish is not acute. That's really what the tension is about, and that's important to keep in mind. So once we set that straight, that we're talking about chronic death wish, then the question is, okay, well, should everyone who has a chronic death wish, right, that's longer than a few weeks, that's persistent, that is unambivalent, right, should everyone receive MAiD instead if they ask for it? Now, again, I take it that most people would say, well, no, right? If you do say yes, if you do say, yeah, sure, a few people, not many, a few people do say that, then if you do so, you need to change the way you do suicide prevention, right? So that would require a major overhaul of suicide prevention because as we saw initially, suicide prevention is very clear in its overall goal of preventing suicide. So I'm going to take it, most people would say, yes, everyone should receive. Again, this is provided they meet the requirements, right? Now, if people say, well, no, really, I mean, that would be the common sense, maybe, right, sort of in between view of, well, no, not everyone should. Then the question is, well, can we safely distinguish between the two, right? So that will be the key question. And so what we'll talk about is, okay, well, can we distinguish clinically? If not, can we do so conceptually? And if not, can we do so on a case-by-case basis? And here is what we will be seeing. So I'm going to argue we can't distinguish for any of the three. And that means we'll need to think, we'll be back to the tension and we'll need to think this through. Okay, so first of all, can we distinguish clinically? So I'll be fairly brief about this, and I'll present my previous work on this. I'll be fairly brief because it's pretty clear that the profiles are similar in the cases, right? That's also the reason that the guidelines already acknowledge that. So I'm going to be fairly brief on that. But the point is that the evidence about the research from the Netherlands shows that there are similarities between those who receive MAiD and those who are chronically suicidal in terms of their gender, in terms of the two most common diagnoses. Depression and personality disorders are the top two most common diagnoses among the MAiD cases in the Netherlands. And they're also the diagnoses that are most associated with suicidal behavior, as we know from the DSM and so on in clinical practice. So this is important to keep in mind: women, depression and personality disorders, but also a number of other risk factors, known risk factors of suicidality, like a history of trauma, like a history of prior suicide attempt, which we see is very common among patients who received MAiD in the Netherlands. And so here's a quote from the Canada expert panel report, where they say, well, whether there's a distinction between MAiD and suicide is a point of debate. Some arguing the two are distinct, others saying they're not, some claiming that even if they're distinct in practice, practitioners cannot tell them apart. I want to say here it's a mischaracterization, actually, because our research shows that the profiles are clearly similar, right? So it's different altogether than to say, well, even if they're distinct, we cannot tell them apart. No, we have to assume they're actually similar. And so this first strategy of distinguishing clinically fails, right? The clinical profiles are clearly similar, and that's the picture that we need to keep in mind. Okay, so that's for the first one. Now, coming to the second one, and as I said, this is the main one, right? This is the most important one, because when people talk about MAiD, what they really mean is, well, yes, conceptually, surely there is a way we can distinguish. And the two main candidates, as we will see, is autonomy on one hand. There's a way in which we can say one is an autonomous decision and the other one is not, or there's a way in which we can say, well, one can be treated and one is not. And we'll see that actually, when we actually do a careful, systematic, ethical analysis of this, we see that that distinction is more elusive than it looks. I'm going to start with the guidelines to look at what do the guidelines in Belgium and the Netherlands say about how you're supposed to distinguish. Okay, so here's the Belgian guidelines, which for the record came out for the first time. So the first guidelines were published in 2017, which is 15 years after the Belgian law came into effect. And they say, in the vast majority of patients with suicidality, therapeutic work is done on and with this suicidality within a trusting relationship. This opinion text is not about that process, but about the response given to a formal MAiD request and the procedure then followed. So they don't really tackle the issue, right? They say, look, what they say before this actually is acute suicidality. So they helpfully make that distinction. They're like, okay, we're not talking about acute suicidality. And then they're saying, well, the majority of patients actually have chronic suicidality, and these are the patients we work with, right? So that's what they say, except they say, well, we're not going to talk about the distinction. We're just going to say, if someone makes an official request, how are you supposed to be careful about it, right? So that's for the Belgian guidelines. Now, the Dutch guidelines do spell it out. So here's what they say. They say patients who exhibit suicidal behavior due to a psychological disorder generally display impulsive behavior as a manifestation of the underlying pathology, where they say the disorder has the patient in its grip, as it were. The patient is usually not fully capable of giving informed consent, and there is reasonable expectation of outcome from treatment. Okay, so we see here the two themes sort of emerging, one being autonomy, one being irremediability, right? Like what is the expectation of outcome of treatment. So we'll look at these two strategies, right? One by one, irremediability and autonomy. Now, on the first one, I'm going to argue it's important to keep in mind the two aspects. One being, is the mental disorder irremediable, but also is the suicidality irremediable, right? And as separate from the mental disorder. So, is the mental disorder irremediable? Now, I want to say the question of irremediability is a huge one in this debate, and we can talk about it afterwards. This is going to be a very brief summary of what the problems are with the with these requirements, right? With how we can find proper standards, right? And we actually can't, because on an objective standard, like Belgium and the Netherlands actually endorse, where they say, look, it has to be a clinician who says that objectively the disorder is incurable. We found in this paper currently in press that there is no reliable prognosis in psychiatry, right? So if you want to adhere to an objective standard, like with physical disorders, you can't, because there is no reliable prognosis. Neither if you want to know, will this patient respond to a list of evidence-based treatments? So that's one. Neither the question of, will the patient recover on the long term? Which is, of course, the important question, because to say something is incurable, you want to say for sure they will never recover on the long term. Okay, so that's the objective standard. If you adhere to a subjective standard, right, like Canada has, where it says something is remediable if it can be remedied under conditions acceptable to the person, then we have no standards for defining what this means. And the problem, specifically mental disorder, is that we have no standards to filter out mental disorder from mental distress that isn't disorder, right? Of course, this is a huge debate within psychiatry itself, right? Psychiatric diagnosis and that line, right? That vague line between disorder and non-disorder. But as a result, it's a major problem for MAiD policy as well. So that is the mental disorder irremediable. I want to point to the second one, which is important and which guidelines are actually silent on, right? They don't say anything about it, and it's an important thing that shouldn't be ignored, actually, is that guidelines assume that treatment of the mental disorder will actually lead to improved outcome of suicidality. This may be the case sometimes, but it's not always the case. That's not the way it works in practice. And in fact, we have separate evidence-based treatment for suicidality. So here's an example. For example, a history of trauma, right, by which we mean severe trauma in the past, is a known suicide risk factor independently of having a mental disorder, right? We know that. We know from the study that I presented before, 36% of the MAiD cases in the Netherlands had a traumatic history, right? We also know that the same percentage almost of women face gender-based violence during their lifetime. When we look at healthcare, trauma-informed care is suboptimal. That's something we all know. And the larger question is really, well, at our societal level, how do we factor this kind of social injustice into irremediability, right? So that applies to mental disorders, but it applies also specifically to whether suicidality in itself can be remedied. And so putting this together, we have suicidality, which may or may not be stemmed from a mental disorder, right? And guidelines assume, right, or they, as things stand, that we need to treat the mental disorder, and that will sort of help us. We've seen the problems with how irremediability is defined, and really what we need to do is also include suicidality, right? Like the question of, is suicidality remediable? Okay, so bottom line of all this is that if we don't have standards for defining irremediability of the mental disorder nor of suicidality, it cannot be a good candidate to differentiate between MAiD and. Okay, so that's for irremediability. Okay, now coming to autonomy is actually probably the more important one, the more promising candidate. And that's often the one that's being invoked, right? When we say, well, yes, suicidality is one thing, but in a MAiD request, really, it's a carefully thought of, non-impulsive decision where a person gives consent, right? So that's a distinction, and we're gonna look at what this means. A brief background, right, on how we do suicide prevention and MAiD. So in suicide prevention, we sometimes go as far as involuntarily committing people, right? And the point is that we have a rather nebulous understanding of what autonomy and consent do in these cases. None of the voluntary treatment laws include consent or capacity assessment, right? So we proceed without doing capacity or consent assessment, which means that there is a range of measures we take. Sometimes paternalism may be warranted, sometimes it would not be warranted or justified, and we have no way to distinguish in which cases it is and is not. So in suicide prevention, it's this whole sort of nebulous understanding, and we just assume that, look, we're gonna prevent suicide, whatever it takes. It doesn't really matter if someone can give consent or not. In MAiD, we assume the request is not impulsive, right? And we assume the person can consent, and usually the context in which this is done is that of a quiet sort of discussion, right? Okay. It's important here to define informed consent, just to keep you, to say how it's defined, right? So the doctrine of informed consent, there are 3 conditions. The decision has to be informed, has to be capacitated, and has to be voluntary. Capacity in medicine is defined according to the prevailing model by Grisso and Applebaum, which consists of these 4 abilities, right? So capacity to understand the decision, capacity to appreciate how it applies to you, the capacity or the ability to reason, and the ability to communicate your choice. Then voluntariness is defined in external and internal. So external is free from undue pressure, and internal means free from internal undue pressure. Okay, so the next question is then, okay, so where does impulsivity fit in? Because impulsivity is what does a lot of the work in this distinction, right? Now, impulsivity, there are 2 different meanings. It's an ambiguous term in that sense, right? There are 2 meanings. One is in a clinical sense of unplanned, right? An unplanned action out of the blue. Think of that breakup again, right? Someone is, I can't take it. I'm gonna jump off the bridge without like former prior planning. Now, in the paper published earlier in the British Journal of Psychiatry, we've shown that this is misguided as a marker, right? We know that the vast majority of suicidal processes are actually not impulsive, or actually carefully thought of. And in fact, we also know that when there is a mental disorder and when there are risk factors like a history of trauma, the suicidal process is less likely to be impulsive. Okay, so in that sense of unplanned, it's not helpful. Now, the conceptual sense of without internal control, that's another question, and that's more promising. Now, what does without internal control mean? It actually means internal voluntariness. That's what internal voluntariness means, right? It means free from undue internal pressure. Now, what's the problem with that? Is that within the doctrine of informed consent, internal voluntariness is the most under-theorized concept of all. We have no tool or scale to assess it. And while external voluntariness, for example, has seen extensive, sophisticated analysis of what amounts to undue pressure versus coercion, right? We have no such thing when it comes to internal voluntariness. So that's a weakness, if you want, of the informed consent doctrine, and one that is very important when it comes to the distinction. As a result of this, as a result of the fact that internal voluntariness is under-theorized, we see that guidance is not equipped to define it adequately. So the Dutch Euthanasia Code, which is the code of practice from the Dutch Euthanasia Review Committees, say the patient must be decisionally competent, between brackets, internal voluntariness. So they equate internal voluntariness and decisional capacity or competence. Right? The Canon expert report says MAiD assessors need to be aware of these types of internal pressures. So kind of non-committal, right? So here we'll see the illustration of the euthanasia code in the Netherlands, where they say, okay, voluntary request, right? What does that mean? There are two sides, and so far so good. First, the request must have been made without any undue influence, right? So external voluntariness, that's right. The second, the patient must be decisionally competent, internal voluntariness. And then they go on to describe what decisional competence means. So what's the problem is that capacity is not the same as voluntariness, right? So we have a circularity problem if we define internal voluntariness in terms of capacity. That's the first one. When it comes to the Canadian experts report, so we see at the beginning, right, one of the eligibility requirement is that, right, voluntary request. So that means it was not made as a result of external pressure, okay? But in some cases, a person's voluntariness may be compromised because of internal pressure. And then they go on to describe some examples, among which, right, the severe childhood trauma, which we know is a major factor. And then they end saying assessors need to be aware of these types of internal pressure to request or follow through with MAiD and have training and experience necessary to detect. Okay, so it doesn't really say though how, right, they're supposed to make that determination. So where does this leave us? Essentially the distinction then, at least in the Netherlands, in Belgium, is reduced to capacity. And capacity, as we saw, defined by these four abilities. Okay, what's the problem with that then? The problem with the distinction based on capacity is that, first of all, we don't do capacities in suicide prevention, capacity assessments, right? As I said earlier, the voluntary treatment laws don't require capacity assessments. So we don't do it there. Second, most suicidal patients would meet the bar for capacity. I mean, they would understand, they would be able to reason, they would be able to communicate. There's no question most people would meet the bar. So it's unclear, right, how this tool is supposed to help you differentiate. Another problem with the distinction based on capacity is that we haven't defined, right, as a matter of ethical analysis, how we factor the outcome, right, and how that's different from what we do in suicide prevention. So the outcome is clear, is death, both in suicide prevention and in MAiD, right? For the way we do suicide prevention, we know that is considered a clear harm. I mean, there's no question, right? That's how it's done in suicide prevention. What's unclear is how it's considered in MAiD, right? Is it considered a benefit? If so, why, right? So we need to be clear about that and be clear about how it's factored, right? How it's defined and how it's different from the way we do it in suicide prevention. And so, as a result of having both, right? Well, what's the problem with having both when we have a tool that cannot distinguish is that we have two types of ethical problems. The first one is paternalism in suicide prevention, right? So when we override people's autonomy when actually we're not justified in doing so, that's one problem. Second problem is providing MAiD based on a tool that may not be equipped for the task. Okay. So far, we haven't found a good candidate for distinguishing. Now, the third strategy is a case-by-case approach, right? Is to say, look, yeah, maybe that's true, maybe we can't, but we'll let physicians, clinicians decide on a case-by-case basis and let them make that determination. Three problems with a case-by-case approach. The first one is that based approach is the lowest level of moral discourse. And I'll illustrate in a second what that means. Second is, if we don't have guidelines for clinicians about such a weighty decision as ending someone's life with someone who's not going to die otherwise, will lead to moral distress. Right? The very purpose of having standards and having guidelines is for clinicians to have something to turn to when they need to make such decisions. So to just then say, well, it's up to you on a case-by-case basis, is not going to be very helpful. And third is that, again, if we don't have standards, the risk is that decisions are made on an individual basis, right, which is what they're tasked to do, based on unconscious or ableist assumptions, right? And that is a potential harm in itself, as I'll show. So the first one, here is an illustration from Veach and Guidry Brown's textbook of bioethics, right, where they illustrate the levels of moral discourse. Now, the only one, you not look at the specifics, but what this shows is that a case-by-case basis is the lowest level, right? It's not very helpful to do ethics or law really based on cases, right? And what we need when we are discussing policies and laws are principles, right? So really the discussion we should be having is at that higher level of ethics and not at the level of casuistry. The lack of ethical standards. Okay, what are the potential harmful effects, right? Moral distress on one hand and unconscious biases on the other hand. Now, it's important to keep in mind that these are actually two sides of the same coin, right? Like someone, I mean, you might have moral distress if you don't know what to do, and you're more likely to act on unconscious biases, right? So it's important to keep in mind clinicians in this context want to do the best for their patients, right? So it's not to say they're more ableist than others. It's just to say, if you don't have standards, the risk is they might act on those. So here's an example from our research to sort of illustrate what this means, right? So in our study of 74 cases, we found Dutch cases who died by MAiD. We found that so some people had mental disorders without physical disabilities, and some had mental disorders with physical disabilities. And we found that those who had both mental and physical disabilities, compared to those who didn't have other disabilities, were more likely to have their MAiD request refused by their treating physician. So you can see that as an indication of moral distress, right? Like when you read those reports, clinicians often were saying, look, this is too much. I don't know how to proceed. So the request was often refused, but at the same time, they were more likely to be referred to the end of life clinic, right? Which is now called the Expertise Center Euthanasia in the Netherlands, where they were less likely to see a psychiatrist before that. Right, so they were more likely to be referred to these clinics and then less likely to actually receive the expertise that was needed. And so this is to show that a case-by-case approach is not ethically neutral. We have the risk of the nebulous understanding of personal autonomy, which in itself we've seen comports two types of problem, right? Paternalism and the inadequate tool. We'll have moral distress among clinicians, and the risk of perpetuating ableism and structural injustice. So the point is that this cartoon, which you probably might have seen before, right? Someone in a wheelchair, and in one hand, suicide prevention program has stairs, and the other one is like a straight entry. We assume the decisions are not going to be based on ableist or otherwise discriminatory attitudes, right? But if that's the case, and we're committed to not doing that, which I think everyone would agree, I suppose, we need to determine what the standards are. And as we've seen, it's more elusive than we would have thought. So to conclude then, we're back at the flowchart, right? So if we cannot distinguish clinically, conceptually, nor on a case-by-case basis, we need to think really about what we're doing and what we need before we proceed, right? And so to conclude, the tension is real and warrants attention, the current strategies fail, and urgent ethical and indeed also legal analysis is needed. Thank you for your attention, and I look forward to our discussion.
Let me invite first Dr. Prasad, Urvashi Prasad, to provide a commentary. I will try to have the speaker. Okay.
Thank you so much. Can you hear me okay?
We can hear you, yes.
Okay, perfect. Thank you for inviting me to this talk. I know certainly this is a topic that is extremely topical, and having gained some of the insights from a country that has had this law in place prior to Canada is truly very insightful. And so thank you to Dr. Nicolini for being able to share some of her research and some of her data from there. I do have a couple of comments written down, and this is both based on the talk today as well as on your research paper on the same topic, which I hope to share today. When I graduated from medical school not too long ago and embarked on my journey of becoming a psychiatrist a little over 3 years ago now, I would not have foreseen that I would be faced with the challenge, on one hand, being adequately trained to be able to recognize individuals at high risk for suicide and to be able to intervene in a timely manner. And at the same time, balancing that with individuals who are asking for euthanasia and who we are allowing to die. To me, that is quite frightening and honestly quite a challenging and daunting task that we'll be faced with as psychiatrists. So I became interested in the topic of MAiD when I heard about the passing of Bill C7 and in Canada, which, as we all know, will allow for individuals to access MAiD in situations where individuals are suffering with primarily mental illness. One of the things that frightens me or causes a degree of uneasiness is the current safeguards, protocols, and guidance that we currently have in place to kind of guide us in the current circumstance that we're in. Particularly, I wonder about how one could safely assess for certain important criteria in order to be able to implement or in order to be able to have individuals accept MAiD in the case of primary mental illness. So these are things such as irreversibility or irremediability, which was discussed in your talk today, capacity, as well as suicidality, which of course is the content of your talk today and very insightful, and as well as social vulnerabilities in the context of mental illness. So this leads me to some of my reflections on some of what was shared here today. Firstly, the concept of suicide capability, which I know was more so addressed in your paper, and one that really resonated with me. The concept of suicide capability being a combination of practical factors where someone has the means and access to ways in which they could plan for and complete suicide. This is often where we as psychiatrists are best trained at in order to recognize and intervene individuals that are at high risk for suicide, as well as some of the psychological factors such as pain threshold and fear, which can be harder to assess for. Learning that removing some of these barriers to access euthanasia may result in what we now know as prior suicide attempts that may translate to completed death by euthanasia is quite alarming. And although I know this wasn't addressed primarily in your talk today, it was something that really stood out to me in your paper, and was something I was hoping to also kind of bring up and mention here. I can personally, and the reason I bring this up is because I can personally recall the number of patients and the number of faces that I've seen both on call overnight in the emergency department, as well as on the medical wards and surgical wards, where we as psychiatrists have been consulted to come in and assess patients with a recent suicide attempt. I can personally recall that a lot of these patients, after having completed suicide or attempted suicide, many of them have looked at life as a second chance and have been thankful for having survived such an attempt. Of course, I know that might be a kind of naive way of looking at it. There are patients that have attempted suicide and have regretted not that they've attempted suicide, but that they had survived it. But the point that I'm trying to make here is that, as you can imagine, it can be hard to predict which patients are thankful for having survived and which haven't. And therefore, I can't fathom the idea of error when it comes to such a situation of that's so absolute and irreversible as death. Secondly, and related to the point of suicide capability is the gender paradox, which I know you talk about a lot in your paper. Much like in Belgium, in Canada as well, the number of suicide attempts by women far outweighs or is much greater than the suicide attempts by men. And so I do share some of your thoughts in identifying factors that might make women in particular more vulnerable to suicide attempts or seeking euthanasia, and finding solutions both sort of clinically in the psychiatric field, but also larger in terms of government policies and to be able to address some of these issues. So these include things such as, you mentioned in your talk, some of the things that make women perhaps more predisposed to our higher level of women leading to more suicide attempts, things such as gender-based violence. And so does that mean that we need to be much more actively screening for trauma and PTSD? And do we have enough adequate resources in order to timely connect people with trauma therapy? Another thing you bring up is in terms of borderline personality disorders. We know that borderline personality disorder, one of the criteria is an increase in suicidal ideation. And although the prevalence of borderline personality disorder is the same within men and women, we do know that women are much more likely to seek help. And so we come into contact with more women with borderline personality disorder in the clinical setting. That being said, one of the first-line therapies, first-line treatments for borderline personality disorder is dialectical behavioral therapy, or DBT. And unfortunately, we do know we don't have enough therapy resources or enough timely access to that. So does this mean, do we need more easier access to various types of therapy? Do we need more OHIP coverage, more OHIP funding to allow people to access this in a timely manner? And of course, this is the psychiatric aspect of things. There might be other aspects, as you mentioned, perhaps psychosocial aspects that also contribute to suicidality, and whether gender has a role in this as well. I know you mentioned in your paper in terms of inequality and gender inequality in pay. And so does this translate to other downstream problems like stable housing? So do we need to have a sort of broader policies in place outside of just in the clinical psychiatric field to help address some of that? As we all know, housing is a huge crisis, particularly in the city of Toronto. And so do we need to have graver, more intensified efforts to be able to find appropriate solutions for that? In sort of my closing comments, the one thing I do want to say, and I think it's important for me to share this, is that I would not say in no means that I am against medical assistance in dying in its entirety. I acknowledge that as a psychiatry trainee, I may have walked beside individuals, I've walked beside patients, but by no means have I been in their shoes. And by no means can I say that I fully understand what it feels like to experience unbearable suffering. My only worry, and the point I want to make here, is that the challenge that arises in being able to safely assess for patients that may meet eligibility criteria for MAiD in primary mental illness, as a margin of error here is extremely slim to none. I hope that as MAiD becomes accessible for those with primary mental illness in Canada, policy changes can occur as ones that we talked about in terms of adequate housing, as well as other changes that might help people access care in a timely manner, maybe a push or a drive for increasing funding for OHIP covered therapy to be able to, especially in light of the change that's about to come in March of next year. And maybe in this manner, we might be able to address some of the issues that are upstream of suicidality or suicide that we see in the context of mental illness. So although it's still frightening and a challenging task to come, I'd like to end with this because it allows me to approach the coming months with perhaps some hope and optimism as we navigate the changes to come in the field of psychiatry. Thank you.
Thank you very much. Dr. Walsh, Samantha.
Hello, is everyone able to hear me? Great, thank you. So I come to this topic today, both personally and professionally, representing DAWN, which is the Disabled Women's Network of Canada. Before I start with some commentary, I want to thank Dawn's research team who helped me prepare this brief and let folks know if they want access to some of the statistics I'm citing or to contact me directly, they can do so through the dawncanada.net website. So I identify as someone with a disability. In conjunction with also holding this position. I have cerebral palsy and use a wheelchair. People with all kinds of disabilities and mental health included, need supports for a high quality of life. So what I'm thinking about is, are folks able to make an authentic choice? Do they have all of their needs met in a society that is inherently ableist? So currently people with disabilities are still marginalized. And when I think about MAiD, I think about my own experience with disability and mental health. I have a disability, but I also have lots of privilege. I'm well supported, housed, and have a rich life with lots of friends and meaningful experiences. Even with that support and resources, it has been a challenge to find accessible, both financially accessible, but also retrofitted housing, meaningful employment, and access to social spaces. Further, there's a lack of media representation of people living good lives with all kinds of disabilities. So I'm not just thinking about representation of folks in wheelchairs, but also representation of folks negotiating invisible disabilities or psychiatric disabilities. And given that society does not actively create space for folks with disabilities, this leads to a lot of anxiety and depression. But I am not anxious because I'm disabled. I'm anxious because I live in a society that doesn't make space for me. When we think about this statistically, we see that 24% of women living in Canada live with disabilities. Intersectionally, there's an overrepresentation of Black or Indigenous folks with disabilities of almost 30%. So we're seeing an over-identification and over-labeling and marginalization of women with disabilities. Further, it's estimated that 33% of these individuals live in poverty and struggle to navigate basic necessities of life. Additionally, there have been cases where folks have applied for MAiD because they can't access housing or can't access resources. the disability activist, Pat Capone, discusses that to have a good life, everyone needs a home, a friend, and something meaningful. I question the ability to make an authentic choice to choose MAiD in a society that doesn't make space for folks with disabilities. I question, and in the work that I do professionally, I meet women who are frustrated and depressed and downtrodden. And I question the tension between, are you suffering your disability? Are you suffering your condition? Or are you suffering a society that doesn't make authentic space for you? And I worry, and worry is an understatement, but I have great concern. Have we exhausted every opportunity to make sure that folks have equitable access to resources and high quality of life before we authenticate their suffering as a life not worth living? I really appreciate the comments of the other presenters, and I implore you all to meditate more on the situation of MAiD. Thank you so much.
Isabel, Mr. Grant.
Thanks very much. And thanks to the previous presenters and to Dr. Nicolini for her work. And I think it's really important to bring gender into this discussion, because I worry it won't be until it's too late in this country till we figure out whether we are disproportionately ending the lives of women through MAiD. I do want to, excuse me, start with a caveat, and that is that I'm not an expert on suicide, but I am someone who works on this issue from a legal perspective. And so what I'd like to do is just on a very kind of simplistic level, because we only have 5 minutes, talk about why does it matter whether MAiD can be distinguished from suicide? Like, why do we care? And I think it's actually really central to the legal analysis, and I'd like to say a little bit about why that is. And I think it's central to the legal analysis beyond just MAiD for mental illness. I think it's central to the legal analysis for all of Track 2. Track 2 MAiD refers to people who are accessing MAiD, who have a disability or an irremediable medical condition, but who are not themselves close to death. So these are people whose lives we are ending, who are not dying otherwise. And the reason I think it's really central to the constitutional analysis is because of what discrimination and equality mean in this country. Section 15 gives everybody the right to equal protection of the law and the right to equal benefit of the law, and the right not to be discriminated against on the basis of mental or physical disability. So how we frame the Section 15 argument really depends on the answer to what is MAiD. What are we doing when we end the life of someone who is not otherwise dying themselves? On the one hand, I think you could frame the Section 15 argument as MAiD is a benefit to people with disabilities. This is how the MAiD proponents frame the argument. It's a benefit because it gives them access to help in a way to end their lives that is presumably less frightening and less painful than some other ways to end life. And that once you frame it as a benefit, everyone has equal access to that benefit, and you certainly couldn't discriminate against people with mental illness because you would be denying them a benefit on the basis that they have a mental disability, which is contrary to Section 15 of the Charter. But if you think of the Section 15 argument in a different way, and you frame it as MAiD is denying people with disabilities equal protection of the law, and that criminal law protects all Canadians from having their suicides facilitated, and it helps all Canadians from having their lives ended by another person, even with their consent. And that therefore MAiD Track 2 has essentially taken this small population of people, all of whom are a protected group under the Charter, and denied them that same protection. So I think you can probably see how the suicide analysis fits into this. Truchon, which was the Quebec case that led to the expansion of MAiD, said essentially that denying MAiD to people who are not at the end of their lives is discriminatory because you are forcing them to live and forcing them to suffer. and that MAiD is a benefit to those people. But Truchon, in order to find that, the court had to go out of its way to say that MAiD is not suicide, because I think it's harder to conceptualize suicide as a benefit without saying all suicide prevention is unconstitutionally interfering with people's right to die. So if you construct MAiD as not being suicide, it makes it easier to think about it as something else and not to impinge on suicide prevention efforts. If you flip that argument and you say MAiD is the facilitation of suicide, then I think it's easier to see how that is discriminatory, because you are promoting suicide for a group of people who are people with a disability, which is a protected group under Section 15. And I would suggest that even the very endeavor of trying to distinguish Track 2 MAiD from suicide is inherently discriminatory, because it's premised on the idea that if you're disabled enough, ending your life is a social good. It's a benefit. Whereas we see all other suicide as something we work hard to prevent, and we see it as a negative or a loss. And I guess I want us to question what is it about disability that makes us think that death is better than life? The Supreme Court of Canada has said in another context that most disability discrimination is premised on the ableist understanding of disability, that it's a flaw or something that needs to be fixed or eradicated. And I think that Bill C7 and Track 2 MAiD entrenched this idea that it may be better to be dead than disabled for someone with a disability, and that is essentially the essence of ableism. And I think this distinction between is MAiD suicide or is it something else comes up under Section 7 of the Charter as well. Section 7 of the Charter talks about guaranteeing everyone the right to life, liberty, and security of the person, and the right not to have those rights deprived except in accordance with the principles of fundamental justice. In Truchon, the court characterized MAiD as being essentially just like any other form of medical treatment. And once you characterize MAiD as medical treatment, how do you say you can deny it to someone who is not at the end of their life? Or how do you say you can deny it to someone who wants to access it on the basis of mental illness? But if we think of Track 2 MAiD as not being a form of treatment, because if it is a form of treatment, it's the only medical treatment I'm aware of that does nothing for the symptoms of an illness and is completely disconnected from the illness, and that eradicates the patient rather than the illness, or seeks to eradicate the patient rather than the illness. But if we see it as treatment, we can't deny it to people constitutionally. If we see it as facilitating suicide, then I think we do understand that the law allows doctors and others to intervene, to pull someone back from the brink of suicide. And I guess I want to just leave with the thought that I really want to question why we do that, why we accept that premise that suicide is a negative, something we want to prevent, why disability changes that calculation, and why suddenly suicide can be constructed as a benefit or something that people should have the ability to access and in fact the state to facilitate. And just in response to Dr. Walsh's comments, you know, the idea that people with mental illness or people with chronic irremediable disabilities have access to a choice to die, but not a choice to live in a meaningful way with the financial and other resources that they need is something that I think we really need to challenge. And I just want to end with a thank you to Dr. Nicolini for really raising the gender question, which has been largely silent in all of the debates I've listened to through the Senate and the Joint Committee. We haven't really heard much about gender, and I think it's really important that we recognize that a history of trauma and the fact that it's women accessing MAiD for mental illness is something that should really worry all of us. Thank you.
Thank you very much. Very much for these three very interesting comments. I would invite Dr. Nicolini to come in the front, and I will take some questions from the audience. Simply as a as a follow-up to what Isabel was saying about the traumatic experiences of trauma and the overlap in gender, I would invite everybody to read some of the case stories of medical assistants in dying from mental disease, for mental illness in Belgium and the Netherlands, and many of them actually relate to very tragic stories of serious abuse, and I'm sure that Dr. Nicolini can expand on some of that as well. Let me first take some questions that the students in this seminar have already forwarded to me, and then I'll open it up to the general audience. So I have Emily Groper. Okay, she's sitting there, Emily. So yes, if you can repeat your question, and I will invite Dr. Nicolini first, and if the panel members want to say something as well, they can follow up as well.
Perfect. Yeah, so my question is two parts. I mean, they relate to under the legislative requirements. It seems that doctors really have discretion to determine whether there are reasonable alternatives. So my first question is, do the applicable laws allow for treatment refusal before receiving psychiatric EAS? And if they do, and an individual can decline treatment, then are autonomy and incurability both necessary requirements? I mean, it seems that the voluntary nature of the request kind of outweighs that incurability component, which I'm curious as to why, if that is the case, why we have the latter requirement at all. And that's pretty concerning if, you know, some of these people could actually respond to treatment down the road.
Thank you. Very well. Yeah. So thank you for the question. Under the Belgian and Dutch laws and guidelines, a person can refuse a treatment. They need not try every possible thing or treatment out there. So there is room for treatment refusal, but the default still is that the clinician should follow, what the guidelines call the current medical understanding, diagnosis and prognosis. So all this clear language about using the evidence out there to determine whether it's curable or incurable. Now the trouble, of course, is if we have no evidence or no possibility to do so, then yes, that goes to the point you're raising, which, yes, irremediability. So I'm talking all under the objective standard, right? I'm bracketing the subjective one, but even under this objective one, these are the problems. And in the case study that we did of these 74 cases, for example, we found that 28%, so more than a fourth, had not tried psychotherapy, which is first-line treatment for personality disorder, certainly, and many other disorders. So bottom line is we saw in practice a wide range of how irremediability then was assessed. And so yes, I mean, the bigger question then is if we think irremediability doesn't do much work, then why do we have the requirements, right? The three key requirements are jointly necessary and sufficient, but you need the three of them. So if we decide to get rid of that, then we would have MAiD based on autonomy and suffering, which I don't think any, I mean, at least that's not the question right now of governments, wanting to do that, because, right, then you get rid of the whole medical condition basis, right? And per definition, MAiD is medical assistance in dying, right? So if you get rid of that, it's a whole thing altogether, which some people advocate for, right? But it's a separate thing. So yes, these are the range of problems that we encounter.
Monica Jill.
So my question was more touching on the research when it came to women and psychiatric EAS. So sorry, my voice is rough today. So I understand, given kind of the proportion of women that request psychiatric EAS, there's a desire then to pay attention to kind of the reasons why that they're requesting it, right? So I was kind of wondering, basically, if we track that research into kind of applying that, would it ever look like, that we're creating more factors to be considered or more requirements on women who are requesting that, despite the issues that would cause with discrimination? Or is it more so a generalized call that we need greater social supports for the underlying reasons why women are requesting it?
Thank you. Yeah, it would be more the latter than the former, right? What we factor into our understanding of irremediability, right? Like, do we understand it as, if we understand it under the objective standard, then what needs to be tried are objective evidence-based treatments. The question is though, if we know some of the contributing factors are based on societal injustice, then the question is how do we factor that into it? The key point really is the competing ethical duty, right, of the government. Like how much should it address those underlying injustices versus allow, right, for or providing, right, that for these injustices. So that's the competing ethical duties that need to be addressed really. When we say irremediable, what has to be remedied?
The panel members, any comments? Okay, so Serena.
Trudeau, can I just say one thing? I just
Okay,
wanted-
Samantha, okay.
wanted to point out that in Canada, the law only requires you to consider treatments that are available to you. So it does not require that those treatments be provided. So if you need something that's not available where you live in Canada, there is no requirement that those treatments be made available to you before you access MAiD. And you only have to consider them. If they're not acceptable to you, you do not have to have the treatments before you access MAiD. And that's right in the criminal code provision.
Yes, that's an important thing. It's also, I mean, Isabel's comment goes to the difference between the Belgian law and the Canadian law, which is at least in Belgium, yes, obviously patients can refuse treatment, but the physician can then say, well, I actually cannot provide euthanasia to you because there are other options. And so it creates a very different dynamic in the treatment relation. Whereas in the Canadian context, it's considered to be still a right, which not necessarily the individual physician, but the system has to provide to the patient, which I think has serious consequences for the interaction between in the mental health context as well. Serena Maggie. Serena.
So my question was for individuals seeking psychiatric EAS who do not have physicians that have been seeing them for some time, who are reasonably familiar with their medical history. Is there a minimum time period in place where treatment must be attempted? And in your opinion, how long should providers work with and treat such patients before being able to weigh in on their case?
Thank you. So as for the official waiting time, so there are differences, right? The Netherlands doesn't have by law a specific waiting time. The Belgian law, for example, does, right? So there are differences, and obviously in Canada, we track to you would have this 90-day period, right? So there are differences across jurisdiction, and the question is, I mean, when can you wait, right? 3 months, 6 months. The one thing, the key point, or what really matters, I think, is that of what standards we use to determine it. I think, I mean, we can't have safeguards before we have standards. And then the safeguards is about how we implement those standards, right? So I think, you know, we could have endless discussions about how long the procedure should be, or, you know, how long the treatment should be. But that wouldn't solve our other problem. Now, as for, you know, it's a great point you raise about, well, how long should the treatment actually have been? There is no official requirement for that. So yeah.
And panel members, any comments?
I just wanted to make the comment, and this bleeds into a bit of the question before. It is also imperative to ensure that folks have some of their structural needs met, and again, like access to things that we already know regarding social determinants of health. So again, like housing and peer support, things of that nature. Often folks with disabilities are isolated and experience the internalization of ableism that suggests to them that their life is also not worth living. So I would like to see an infrastructure that has intensive case management before someone considers MAiD.
Okay, thank you very much. Yasmin, Anthony. The thing there, yeah.
I had two. Should I just pick one or the other? Or is there a specific one?
I found your second one the most interesting one.
So
start with the second one.
Sure. As I was trying to wrap my head around gender discrepancies in suicide and attempted suicide, I came across some literature that differentiates between parasuicidal pause, gesture, and serious suicide attempt. So specifically with parasuicidal pause, it refers to suicidal behavior carried out mainly to escape from an unbearable situation or from problems. And there's less of, and they use the word intent a lot, so there's less of an intent to die compared to serious suicide attempt. So the research on this is not consistent from what I found in my brief look. But if this is the case, and it's true that women fall under the former categories more, which is what I also found, how would this play into policy around what constitutes, for example, unbearable psychological suffering? Because we already see this becoming an issue. There was a case in Ontario about a woman that could not find adequate housing and chose euthanasia instead of suffering despite continued efforts by herself and her doctors to remedy the situation. So while not explicitly due to a mental disorder, this shows a failure of our public system and state provisions that drove someone to choose death over an intolerable situation. So yeah, going back to my question, I guess, how would that play into?
Yeah, so one thing I want to say is that very broadly speaking, we know suicidal processes of women are longer than they are for men, and we know men more often complete suicide than women do. We know from the literature that it's not because women are ambivalent or want to seek attention or say it but actually don't really want it, right? Like I guess it's a just verification of the actual tension we're looking at is those who are chronically suicidal who really want to die. I mean, who are unequivocally, unequivocal about their death wish and who haven't died because of the method question, right? Like of how, efficient, let's say, the method was, like how, so, or how lethal really it was. So we know that that's what accounts for the difference. Now, of course, there is parasuicidality, right? Now, that's a thing, but I think it would be wrong to assume that suicidality in women amounts to parasuicidality, right? Like, so yes, I think that the parasuicidal thing is an added question, but which we need to factor into. I see it like the acute suicidality thing, which is also part of the tension, but a minor part, right? So it's all important. The acute suicidality thing issue is also important for the tension, right? Like it also raises a question because presumably someone could also receive MAiD when they're actually acutely suicidal, right, within a week or two. So I mean, not officially now in here, right, in Canada, but so yeah. So I just want to say, yeah.
Maybe if I can ask a question and then we open it up to the audience.
Yeah,
Oh, actually, if somebody of the
Yeah, that was me.
Sorry.
I just had a quick comment to make in regard to the previous question, which was asked about the requirement for duration of treatment prior to accessing MAiD. So there is an expert panel that was created after Bill C-17 was passed, and this panel, some of you might know or be aware of, compromises of both psychiatrists, lawyers, and a bunch of other individuals as well. And so one of the recommendations that they had made actually does speak to your question around duration of treatment. And it took me a second just to find that document, but here it says, it's not possible to provide fixed rules for how many attempts at interventions, how many types of interventions, and over how much time, as this will vary according to requester's baseline function as well as life goals. Therefore, this must be assessed on a case-by-case basis.
Thank you.
Okay, so thank you very much. So if I ask a quick question, in the parliamentary hearings and also in the debates, and also actually in the Truchon decision, the judge embraces the statement by the American Association of Suicidology about the distinction between MAiD and suicide. And this was actually read as a statement also in Parliament to emphasize there's a big difference and it's established. Do you want to comment on these guidelines with respect to their applicability to the Belgian, Dutch, and now also Canadian context? Because in my view, when I read these, there are several questions to be asked about the guidelines, but certainly also that they may not apply to the context of Belgium, Netherlands, and Canada.
Yeah, so that's essentially what we're doing. That British Journal of Psychiatry paper is look exactly at what the American Association for Suicidality had to say, right? They said there are two distinct clinical profiles. Now, if you look at that document issued in 2017, it's primarily based for the US, of course, which doesn't allow 89 right beyond terminal illness. So it's most of what they say is true for that particular context, right? They do, however, say that what they've said applies to mental illness as well, except they also say, well, there might be a degree of overlap, we don't know, so it's an open question. So actually, while they're firm about what it means in context of terminal illness, they do leave it open. And as I've said, our research shows that they're not distinct. I think we need to be very clear about at least the clinical facts and the evidence we know that they're similar.
Okay. Any comments from the panel? So let me open it up to the audience for other questions. We can go back to the students afterwards. I have some questions of students who could not attend, but okay. Dr. Gain.
Oh, thanks. But if anybody else has a question, I'd prefer they go first if the students have any. But otherwise, I'll go ahead. I'm Sonic and Marie, thank you so much for the talk. Fascinating. I've got one comment and then a question for you. The comment is about this idea of whether these are different populations who get MAiD for different reasons. You're alluding to the AAS, the American Association of Suicidology. And yes, they're largely talking about when MAiD is there for end-of-life conditions. So the question is it the same people who seek it in those conditions versus when we open it for non-dying disabled? And I think your work and others shows that they're different populations. One is with the gender gap, right? The 2-to-1 women who get psychiatric euthanasia, whereas it's a gender balance when it's for end-of-life conditions. But you also find differences in psychosocial suffering. So when there are end-of-life conditions, people tend to come from higher levels of privilege and education, and different racial backgrounds tend to be white. When you go to psychiatric euthanasia outside end-of-life conditions, people have unresolved social suffering, poverty, loneliness, and by 2-to-1 margin tend to be women. So it's clearly different populations. The question I have is this, that
between end of life and non-end of life.
Correct, exactly. And seeking it for different reasons, some of the issues people have discussed. The question I have for you is this, that in terms of the expert panel, and thank you for pointing out some of the things that they mentioned, one of the things they also said was that society is making an ethical choice to provide MAiD or allow MAiD for certain individuals, regardless of whether MAiD and suicide are distinct entities. And I just want to hear your thoughts on that, because I don't know if Canadian society has actually made that ethical choice. Basically,
thank you for that. I actually had, let me just pull up my my slides, because I had this quote from them in anticipation of a possible similar question. Wait, sorry, one second. I think this goes to the passage that, wait, how do I? Oh. Okay, so here's what they say. In fact, at the end of this distinction question is, clinicians do not always prevent people from making end-of-life decisions. In situations where there's no acute crisis and the person is capable, clinicians will encourage preservation of life through all therapeutic mechanisms available, but do not go as far as to prevent a person from acting in every situation. Right, so they're saying, we already do this in suicide prevention. And I mean, that goes to your point. Not really. I mean, that's not how people understand suicide prevention to work. So if you want to claim that in clinical practice, we make a distinction between those those whose life we actually preserve, and those who we don't prevent and that die, then it needs to be clear there too, based on what you make that distinction, right? So that goes to the flow chart, essentially, of we can't just be complacent and sort of allow both and say, we'll figure it out on a case-by-case basis, because we've seen we have no standards to define these. And we can't appeal to saying, oh, we already do that in suicide prevention, because that would be news to a lot of people. So this is important actually. And yes, it goes to, action is needed, and just let this happen.
Doesn't this also suggest or go to the difference between the moral difference between abstaining from physically intervening and inducing that and actively doing it? So in the sense that not just because the Supreme Court rejected it in the end of life context as being morally distinct, but here we're talking about an out of the end of life context, about the context where you would basically abstain because it's heavy to impose something on somebody. But it's a very different thing from actually intervening, with the lethal injection. And does it have implications also for the doctor-patient relation and the mental health context?
Yeah, so for this argument to work, one, you need to say, like they say here, that we already do it, and that would need defense, right? The second is that you need to prove that indeed letting someone die is morally equivalent to ending their lives. And that in the ethics literature, no one has made that argument. I mean, you can make it, but you need to defend it. You can't just assert it. Most of the ethical and philosophical argumentation around this allowing this discussion has been done, as you say, in this very narrow end of life situation, where the question is, well, if we increase pain medication, how far can we go before it's treatment, right, versus euthanasia, right? And sometimes it's a very thin line where, you can debate whether there's really a distinction between doing and allowing. It's a whole different situation though, when someone is not going to be dying. So you can't just assume that letting someone commit suicide is morally the same thing as ending their lives. So it needs defense, right? It can be, but it needs to be defended.
So maybe we'll close the quote and see if the panel members want to say something.
I'm sorry about that.
Do you want to comment on anything, Isabel, Samantha, and Rashi? Last question, okay.
I'd like to ask if the person's will to die is so strong and you're including mental illness. I'm still confused if the safeguards are in place. But if you're including mental illness and their will to die is so strong, otherwise being accepted for MAiD, wouldn't they choose suicide? Isn't that a concern?
Sorry, could you repeat the last part? So if it's so strong,
if their will to die is so strong and they've been denied access to MAiD, would the next concern be, would they attempt that suicide themselves?
Yes, I see what you,
Because I'd like to add that I had a euthanasia application forwarded following my mother's social media campaign. So I've been denied my access to MAiD. Yeah, I still have pain and suffering.
Thank you for your question and for sharing. In terms of what will happen, I mean, I can tell you what we know from the Netherlands and Belgium, where only a minority of patients whose request was denied, ended up dying by suicide. Now, I don't know how much. I mean, the question is how much it matters, because what matters is, right, the suffering of the people even after the request is denied. I think, all I can say is that is the distinction question, right? Like people who are suicidal chronically suffer unbearably, right? So that's why we haven't talked about suffering, because I'm assuming that the unbearable suffering is there. I mean, as a society, we assume, right? I mean, we're not contesting that. And in fact, as a progressive ideal, we can agree that some cases would warrant our compassionate assistance, right? So the question, we do it in a safe manner, where we know exactly what happens with those that receive it, those that are denied. So we really need to pin that down, that distinction. There's no way around it.
And I invite the panel members to say something.
I think I just wanted to add one thing here, which is as a society, and I guess as psychiatrists as well, we can do our best to, we can't prevent all suicides. We can do our best to intervene when we do believe there are certain barriers or certain aspects of perhaps mental health that might be contributing to suicidality. So for example, if someone is profoundly depressed and has suicidal ideation from that context, that's an opportunity to really intervene and help treat that depression. Or whether it's in regards to someone with borderline personality disorder and suicidal ideation, again, an opportunity to intervene. And also, if it's not psychiatric, what are some of the other barriers, some of the other reasons why someone is expressing suicidal ideation? Is it because of psychosocial barriers? Is there an opportunity for us to be able to help and to be able to intervene? I think the person who asked the question, you're right, we can't prevent all suicides out there, but we can do our best at trying to help when there is an opportunity to help and intervene.
And I guess if I can just add one comment to that, and that is that I think we need to think about which mistakes are more serious. Like, on which side are we willing to err? You know, are we willing to err on ending the life of someone who could be given supports and help? Or are we willing to err on the side of, no, well, let's just provide MAiD to anybody who wants it in the moment? And I think we really need to think about the consequences of doctors being infallible, not being perfect predictors of the future, and sort of how many mistakes we're willing to tolerate and in which direction.
I tend to frame that as err on the side of life or on the side of the termination of life. But what I also maybe would want to invite psychiatrists here in the room is to comment briefly in light of this very challenging and very difficult comment about the role of hope and mental health treatment. So I read some very interesting papers in psychiatric literature around hope as an essential component in the treatment for mental illness, for suicidality, and so on. I mean, is that something that is being abandoned in the context of the push for MAiD and euthanasia?
There are different ways to answer this question. I think in the literature, in the debate around this topic, often the critic has been that we can't, provide false hope, right? So which goes to the prognosis prediction, right? So one thing is to say, well, psychiatrists need to give hope, and then some understand is as saying they're saying everything will be all right, when actually they have no idea, because we know prognosis prediction is unreliable, right? So that's not what it's about. But the question of, of course, hope, what's therapy? How do you work with someone? I'll just finish my thought 1 second, but I'll come back to you. I just want to say that as things stand, just as a reminder, the first guidelines in Belgium, for example, came out only 5 years ago, right? So even countries that have had the law for 20 years are still learning. And we don't know things like what's the effect for a psychiatrist who has a ward, let's say. How are they supposed to, therapeutically deal with that with the other patients, like that kind of thing. So how you operationalize hope in your treatment when we don't really know how it all plays out in practice is still a question. Yes.
I just wanted to leave with one thought. Could suicide prevention be considered, could medical assistance in dying be considered a means of suicide prevention to maybe have that person have the option to end their life, but in knowing that they can and they will when they're required to do so, then having that option might also allow them to change their mind in the future?
It's a great question. I mean, that's exactly the core, I think, of this talk, is if we do so, yes, we need to change the way we do suicide prevention. Like, we need a lot of work to And what does suicide prevention mean in, say, this country or in this society? So theoretically, yes, we could, but we need to have that debate.
In the Belgian context, what happens is you actually have a treatment arm continue at the same time as an exploration of the MAiD assessment. Huh? I mean, and to some degree to it.
Yes. I have comments on it. Yes.
Yeah. Maybe the very last question, because we started a little bit late and then we have to conclude. Okay.
Sorry, I'm sorry, it's a bit of a comment. I'm a psychiatric nurse with 48 years of experience, so I definitely have seen people who've made almost lethal attempts and being grateful to be alive afterwards. But I'm also a relative of people with bipolar disorder. And I've had relatives who have spent 6 years in and out of hospital, suicidal at times, who are very well recovered now. So I think erring on the side of life is really important because people do recover.
On that very important note, I think we have to conclude this session. Please join me in thanking